You're listening to Beyond the Endpoint, a podcast from the Duke Clinical Research Institute. In this series, we're demystifying clinical research and answering your pressing questions about health and healthcare. You can find our full episodes at dcri.org/BTE.
Imagine running a half marathon one weekend and receiving a life-changing diagnosis of colon cancer the next. That's exactly what happened to one of our guests for today's episode. While colorectal cancer was once considered a disease primarily affecting older adults, trends show it's increasingly striking younger generations, people between 25 and 55. This shift has prompted the American Cancer Society to update its recommendations, now advising screenings beginning at 45 for those at average risk. Today, we have the privilege of talking with our colleague, Dr. Ajay Kohli, an emergency room physician at Duke University Hospital who was diagnosed with colon cancer at the age of 42. Later in this episode, we will be talking to Duke gastroenterologist Dr. Julius Wilder, who has witnessed this rise in younger patients firsthand. I'm Dr. Emily O'Brien, a population health researcher at the Duke Clinical Research Institute. I'm joined by my colleague, Dr. Manesh Patel, head of cardiology at Duke Medicine and DCRI faculty member.
Thanks, Emily, and thank you, Ajay, for sharing your story. To start out, let's go back to 2021. You were balancing life as a busy ER doctor and a father, and you even ran a half marathon the weekend before you received the diagnosis. Could you walk us through that pivotal moment?
First of all, thank you, Emily and Manesh, for having me on this podcast. It's an honor to join you both. Yeah, so back in 2021, I was having a great summer with the kids, with the family, did a bunch of beach trips. But as you mentioned, I am an avid runner, and I'd been training for a half marathon. And it was in late summer in August of 2021 that I started developing some vague abdominal pain. I'm usually pretty dismissive of my health. And so I told my wife about these episodes, and she was a little bit more concerned about them. One episode took place when I was actually at work and a resident was presenting a patient to me, and I almost passed out. I had to excuse myself. And, I just felt like that was quite unusual and something might be wrong. But I still was like, it's probably just too much coffee, and dismiss the symptoms. My wife sat me down one day and she was like, "You're not getting up from this couch until you do something about this, because you're not the type of person to complain of pain, and there's something that we need to figure out." A few weeks later, I had an appointment with GI. And prior to that appointment, I had a whole slew of labs, a CT scan, which thankfully were all negative. And I met with the GI doctors, and they said that given my age being 42 at that time, being close to the screening age for colon cancer, and also the persistent symptoms I was having, that I should pursue a colonoscopy. And I kind of laughed it off and scoffed at that notion. But again, my wife forced me into pursuing the colonoscopy. So fast forward to October 17th, I get up in the morning, I go to the half marathon, have a great race. I'm not having any pain. I feel great, was happy with my outcome. And that evening I start the prep. So that's Sunday, October 17th, start the prep. I'm doing the prep and everything. I feel okay. October 19th, we wake up and I kind of look at my wife before heading to the GI suite and was like, "I feel great. I don't know why I'm pursuing this. My symptoms have resolved and I really don't need to do this. We should just go get some pizza." And once again, she's like, "No, we made it this far. We should just go ahead and get the colonoscopy." So they sedate me. I go for the colonoscopy. And then sometime later, I wake up and I'm groggy from the sedation. But I can hear keywords like perforation, mass, cancer, and the look on everyone's face. And so I got whisked away from the GI suite to the emergency department. And what had happened was during the colonoscopy, they had discovered a relatively large mass in my sigmoid colon. And when the GI doctors went to biopsy it, it perforated the wall. And so that's what led to me going to the emergency department, because once you have a perforation, you have bowel contents leaking out into your abdomen, and you're at risk of sepsis and serious infections. And so I got diagnosed with cancer and a perforation all on the same day, went to emergency surgery that night at midnight. Shortly after my surgery, they had recommended me starting chemotherapy for 6 months. The chemo was brutal itself. I was quite symptomatic, and I was going in every couple of weeks, getting chemo, getting the infusion, going home, feeling bad for a couple of days and feeling better. And as soon as I was feeling better and going for walks, I would be right back in the chemotherapy infusion center. And so that happened for 6 months. And then little by little, I was going on increasingly long walks with my wife and my kids and other family members and friends until I built up the strength to get back to where I am today.
Wow. That's a truly incredible story, and so grateful for your willingness to be here and to share it with us. So many sort of interesting aspects of this. My first takeaway is everyone needs a wife, I think, particularly particularly for those of us who don't love to go and be evaluated and always are postponing our own self-care. So amazing that she was there for you and really encouraged you to go through with the screening. I also heard a couple things that, as someone who thinks a lot about high-level population health data, I think adds some dimension to the national trends and sort of national numbers around this topic, which is we know that colorectal cancer incidence is increasing. We know that a lot of the increases that we're seeing are in younger people, these sort of young invincibles, if you will, like people in their 30s and 40s who may not even have a primary care provider because they feel like the health system isn't an area where they spend a lot of time as a patient, don't really need that kind of care at this point in their lives. And then also, obviously, the fact that you're a physician who has been every day in the healthcare system and seen how it operates and has medical training to process what's happening. I imagine it was really surreal to come out of anesthesia and have that moment of realization, hearing, as you said, the words perforation cancer. I'm sure that takes an incredible amount of processing. Was there a moment where it really sunk in for you, where you were able to set aside maybe the medical training and the academic mindset and take on this new identity of being someone with cancer?
Yeah, great question. I want to go back to a word you mentioned, process. Honestly, my diagnosis happened so quickly that at the time I didn't really have a chance to process. Usually you'd get diagnosed and have a stage sort of surgery, but everything happened so quickly for me that in that moment, I didn't really have any time to process and honestly had to just trust the surgeons and trust the team that was taking care of me in that immediate moment. I think I didn't really start to process until I started seeing a therapist. I'd never seen a therapist before, and I think she really helped me process from a patient perspective and as a person rather than from the physician perspective. And so that was the first time, I think, several weeks into my diagnosis and treatment that I was really able to process what I was going through and how I could deal with this going forward. And when I stopped reading articles and stopped reading things about treatment and took the time to focus on myself and my recovery.
Can you share a little bit maybe about reluctance on going through colonoscopy and maybe how we can change that reluctance for others who might be feeling some of the same things?
I was reluctant for a few reasons. One is I didn't think that I had anything dangerous going on. I was young and healthy. There's no way that I had cancer and colon cancer on top of that. And number two, honestly, the prep, it's not the most fun thing to do. You're drinking a lot of medicines that make you use a restroom and it's uncomfortable. But in hindsight, I'm grateful for having done that. I think it's a small sacrifice to make to get the diagnosis and treatment, and frankly, was a lifesaver. I was under the age where people are now screened routinely, which is 45. And so I would encourage people, if they're having symptoms, to meet with their healthcare providers and physicians and explore whether a colonoscopy would be necessary. There are some other non-invasive tests for people who are at low risk, and I would definitely encourage people to explore those. Colon cancer is now the fourth most commonly diagnosed cancer in this country and the second leading cause of cancer death, so it's nothing to take lightly. And I've anecdotally, since my diagnosis, I've met several people who were diagnosed with little to no symptoms with stage 2, stage 3, even stage 4 colon cancer. So the short of it is it's a small price to pay for something that could be life-altering and life-saving.
That's really helpful. And certainly, as you highlight, we don't ever really know all of the things going on in our body despite our best efforts. And so if you're having symptoms, seeing a healthcare provider is good. And certainly if you're in an age for screening, makes a lot of sense.
Ajay, I was hoping you could talk a little bit about the recovery process. Like once you got through chemo, how did you kind of settle back into normal life, even though it's a new normal for sure? And how are you doing now?
The recovery process was long, as I mentioned, from both the surgery and the chemo perspective, because they both took a big toll on my body. What helped me through the process was my wife, my kids, my family. My parents are nearby. My sisters are nearby. I have great friends here. I'm still an avid runner, and running is my number one therapist. And so what really got me through is initially taking long walks as I could, and then expanding that to longer runs. And then the day I finished chemo was great because I knew I was done with that process. And so I started increasing my runs. And since that time, I've had routine colonoscopies every couple of years. I get labs and CT scans every few months as part of the surveillance process. But overall, I've been healthy, and I think I'm more in tune with my health thanks to my wife. So when I do have other issues beforehand, I might have been dismissive of them, but now I take them more seriously. And it's given me a new perspective on my own health, my own well-being, and helped me sort of change my priorities, especially given the 3 young children that I have. So, it's just a life-shifting experience.
Yeah, it's really powerful. And I'm so glad that you're doing better. And one of the questions I thought as you were talking, Ajay, was just like, you've gotten to see multiple sides of our systems in healthcare. How's it changed you as a clinician and a physician seeing people now?
Yeah, I'd say immensely. I work as an ER physician, so we don't always have the most amount of time to spend with patients in a frenetic ER such as do. But I have slowed down, ironically. And when I see patients, I tend to get their story, and not just their medical story or what brought them to see me on that particular day, but sort of what they like to do, what they might do for work, what their family might consist of. So I think I just try to slow down and build more of a connection with my patients. And I think that's been a result of what I went through, because I try to empathize more with, this might be the worst day of their life. I know how to take care of them medically, but I'd love to get to know them more socially and what makes them a person.
It's really amazing to hear the ability that you have to take some of these tidbits or silver linings from this experience, which of course is transformative for anyone, but to be able to bring them into your practice and into life and allow that to reorient you to what matters, I think is such an incredible example really to set. So thank you for sharing that. Tell us what's next on the road for you.
Yeah, so one thing I want to mention is I do that race every year. So it's every October, that half marathon. And generally speaking, I try and stay healthy. I've tried to cut out or limit the processed foods that I eat. I stopped drinking alcohol last year. So I've tried to make some dietary modifications to help prevent this if possible, because there is more data showing that colon cancer, there are a lot of lifestyle modifications that can help prevent that particular disease. And I'm back to work full time. Between work and my family, I always make space for running and for working out and staying in shape, and just trying to be as positive as I can and spend as much time as I can with my kids before they leave the house.
Well, that's fantastic. And I'm struck by a couple things. Margaret Mead has this quote, you may know, as an anthropologist, said that we knew civilization was occurring when there was the finding of a healed femur, and that somebody cared enough to help another organism get better. I think your story highlights the opportunity we have to show compassion every day and learn from each other. So I really appreciate your story, Jay, and I hope it touches others to do some of the things you're doing.
Thank you so much for being so open about your story and reminding us all about why screening is so important. It's a really great reminder to prioritize our own health and get that screening done, even when we're reluctant or it feels like we don't have a lot of time.
Thank you very much. Again, thank you both for having me. And just one more quick plug. I think since my experience, I take the time to work with residents and other physicians or other colleagues who are in their career, that not to forget about their own well-being on this journey.
For sure. Thank you so much for sharing that. That's a critical message.
This is Beyond the Endpoint, a podcast where we bring personal and expert perspectives on healthcare and clinical research to the casual listener. Stay tuned after the interview for a breakdown with the hosts. They'll talk through key takeaways and what this week's topic means for you.
For the second part of our episode, I'm speaking with Duke gastroenterologist Dr. Julius Wilder about the increase in colorectal cancers in younger patients and what people need to know about the latest research. Julius, thanks so much for joining us today.
I'm happy to be here, and I really look forward to this conversation today with you.
Julius, one of my favorite parts about hosting this podcast is getting to hear the inside story of how people got to where they are. So can you tell us a little bit about how you came to this field and where your interest in gastroenterology started?
Sure. Yeah, I came to GI relatively late in my training. I didn't know I wanted to do it going into medical school or residency. It was later in residency when I had an opportunity to do some GI that I began to realize that it provided me an opportunity to do procedures, which I enjoy doing, as well as take care of a unique patient population in terms of patients with chronic liver disease and transplantation. And so that combination really kind of drew me into it. And then we can talk about it later on, but the idea that there were ways through things like colon cancer screening to have a direct and positive impact on issues related to health disparities was also a big draw for me, given my background, respect to my PhD in medical sociology and the sort of underlying causes of social determinants of health.
Well, it sounds like a perfect fit for somebody who's interested in a really complex problem with a lot of determinants. And speaking of a lot of determinants, it's been an interesting time as somebody who's really more of a kind of consumer of the news in this area and paying attention to the research a little bit. But it's kind of impossible to open the news today and not see something about the rise in cancer incidence, particularly colorectal cancer incidence, and especially in younger people. And so this has been concerning to a lot of us. Can you tell us sort of how, as a researcher, you think about these trends and any major contributors you think might be driving this?
Yeah, it certainly is a real trend that we've seen. And in fact, given the rise in colon cancer among people at younger ages, we've actually moved the screening guidelines instead of starting at age 50 down to age 45. That happened around 5 or so years ago. When we look at the outcomes with respect to colon cancer, we're seeing individuals of all backgrounds in all spaces, particularly in the United States, develop, unfortunately, colon cancer at much earlier ages. The precise etiology for what those links are in terms of younger age and colon cancer is unclear. There's a lot of research being done right now to understand more about that. There are some hypotheses around the impact of things like obesity, a rising issue among younger people, sedentary lifestyle, and how those two may correlate to drive risk of colon cancer, issues around diet and alcohol consumption, particularly diets that are high in red meats. And also, there's some interesting research being done to understand the impact of things like the gut microbiome, or perhaps how that is impacted by all the things I just mentioned, as well as microplastics, which is something that we're beginning to learn more about, generally speaking, in medicine, and explore how they may be driving various health outcomes, including possibly earlier colon cancer.
Yeah, it's so interesting when you see these trends and you see the headlines that say, alarming increases. And I think it kind of invites a lot of us to wonder like what we're doing that might be contributing, and our own risk is being impacted by some of these things. And then people will also talk to me sometimes about kind of strange headlines that they see. Like there's a New York Times article that it was a small study apparently, but they found that colon cancer risk was higher for extreme runners. So this is like certainly opposite of what we might expect, that folks who are fit and have high activity levels and presumably fairly low BMI still may have increased risk. And so, I mean, when people come in like your day-to-day life and sort of ask you about these things, how do you help them like sift through all the different factors that are sort of being thrown up against the wall? Do you give your advice based on anything that you read that's recent, or is it more of sort of a longer term understanding that you kind of use to anchor those recommendations?
Sure. We know that there are certain things that we do as individuals that increases the risk of us developing polyps. And that's important because colon cancer really develops from polyps. And so anything you can do to minimize your risk of developing polyps can have a positive impact in terms of minimizing your risk of colon cancer. And so we know that, again, eating a diet that's rich in fruits and vegetables, meat is okay, but a diet that's too high in red meat can be a problem. We know that too much alcohol, smoking. We also know that sedentary lifestyles and obesity, poorly controlled diabetes, like these are things that correlate clearly with one having polyps and therefore increase the potential risk of an individual developing colon cancer. There are some things that are outside your control, however. There are certain syndromes like Lynch syndrome that are purely genetic things, genetic anomalies that unfortunately creates an environment due to mutations that increases your risk of developing cancer. And that's not something in your control other than to ensure that if diagnosed with one of those genetic conditions, that you're getting appropriate screening to ensure that we protect you from developing cancer down the road. So I typically have that initial conversation with my patients when they're asking about things that they can do to mitigate their risk in terms of polyps and then colon cancer. The idea of what we've seen in terms of the runners in colon cancer is very interesting. It was a very, very small study. And so, we've got to be careful about how we look at it around sort of correlation and causation. But we suspect that what might be happening in that extreme marathon runner population is that in the setting of running, it's leading to sort of periods of ischemia and damage to the bowel. And in the setting of that ischemia to the bowel, you're creating an environment in that space where you can have an opportunity for mutations and then growth of cancer cells as the bowel tries to recover from that insult. Not really clear exactly what the mechanisms are, and it's still a small study and a lot more work to be done to understand that. But that's one of the theories that are out there when they look at this sort of correlation that's been seen. And a lot of that work primarily actually highlights the presence of polyps adenomatous polyps, which are not necessarily cancer, but precancerous, as opposed to runners having colon cancer, frankly. But there's a lot of data and research to be done to better understand those early findings.
It's so interesting also, and it reminds me of the theme that's come up on some of our other episodes, which is stay humble and don't assume that we know everything about causes of disease. We have lots to learn, and they're really bright minds like yourself who are thinking about this every day. So I know we're going to increase our knowledge with time, and sometimes it just requires a little bit of patience. But in the meantime, you talked about screening, and I'd love to hear your thoughts on the updated screening guidance, which I think really intersected with a lot of the science to heighten attention, heighten the spotlight on this topic. I assume, that screening guidance, of course, as a population health person, epidemiologist, I'd love to see our screening moving in the direction of evidence, right? Can you tell us a little bit about what you think this means for individual patients in public health and how it might help people who are already at higher risk?
Yeah, I think you really made an important point there around, evidence and science driving our policy around screening. We were seeing clearly that colon cancer, and not just colon cancer, but larger, more advanced polyps were being found in younger people. And then when we looked at subpopulation or subgroups, we could see clearly, for example, among African Americans, that they were getting colon cancer at much earlier ages as well. So in that setting, it became clear to the various medical societies and screening guidelines that it was time to rethink when we started colon cancer screening, particularly because, again, the evidence showed that if you do colon cancer screening, you have a very significant impact in terms of people developing colon cancer and dying from colon cancer. And so was that evidence around, broadly speaking, polyps happening earlier in life, colon cancer happening early in life, that really drove the decision to move the guidelines back.
So there's certainly like what we think of as conventional screening that happens in a clinical setting, but then we're also seeing a lot of these consumer facing products like, oh, spend $50, get your fit test at home, do it in the privacy of your home, send it back in, and we'll tell you if you need to go see your doctor. I imagine that those have some potential positives, but potential downsides as well. Can you talk a little bit about how you think about some of these sort of consumer facing approaches and whether those technologies on the balance have had a good impact on population health?
The idea of leveraging some of those consumer facing and non-invasive colon cancer screening tests, it's a good idea. Any screen we can get is a good screen, so to speak. And I think for some individuals, if they live in spaces where they don't have access to gastroenterologists in colonoscopy or flex sigmoidoscopy, leveraging these non-invasive tests is a great way to get them initially screened. There are also individuals, regardless of where they live, that may have insurance issues. They can't afford the full colonoscopy, but they're able to get the non-invasive testing done. Again, a great way for us to initially get people screened that may have, for any number of reasons, including their own personal choice, barriers to getting the initial colonoscopy done. That's the positive. The negative is that some of these non-invasive screens and patient-facing screens are more focused on identifying cancer as opposed to really identifying polyps. And so know that if over 10, 15 years, you're really only doing those non-invasive tests, it's very possible that there are polyps in there that are growing over time, but are not quite cancer yet. So that's one thing to keep in mind. The other thing is that if they do identify a concerning polyp or cancer, a polyp that's more advanced or cancer in that setting, you're still going to require a colonoscopy. And so one of the issues is making sure that when people are given these non-invasive tests, that they actually do it and send it back. And then also making sure that if it's a positive test, that they get appropriately connected to getting the colonoscopy done, because that's a very important step as well.
And I know you're doing some interesting research in this space also focused on screening. Can you tell us a little bit about what you're most excited about?
Yeah, I mean, you touched on the fact that these are sort of consumer-facing, non-invasive tests, and it allows us to think about how we can bring screening to those populations that have typically had issues in terms of getting appropriate screening. We look at where the populations that are seeing higher rates of colon cancer. And one of the correlating factors is that they are in spaces with less healthcare resources, including GI. And so we've partnered through funding that we received from the American Board of Internal Medicine, as well as from an important colleague and collaborator, Health Monitor, a patient-facing health information company, where we're able to get non-invasive fit tests and bring those in partnership with some of our community partners when they're doing community events in spaces where we know there may be barriers to getting colonoscopy. And we go to those spaces, we provide education around colon cancer screening, and we also hand out fit tests. And the community has been very receptive to it. That having been said, our goal is to understand how well does this approach work, particularly in those communities that have been harder to engage and harder to reach in terms of getting them appropriate colon cancer screening. And what we've learned is that we can bring things to these communities, but it's important that we think about ways to provide navigation to ensure that those tests that we give out are actually brought back or sent back for testing to ensure that they are positive or negative. And then the next piece being, if they are positive, thinking about ways to connect those communities and individuals who have positive tests to colonoscopy. So those are some of the things that we're working through right now with our community partners through surveys and focus groups to think about better ways to bridge that gap.
This is a really intriguing part of this because even if you do everything right on the screening front, you're going to need to provide, as you said, some pathway to help people navigate what comes next if they're positive, right? And ultimately, feels like it almost becomes a policy question pretty quickly about providing coverage, for example, for follow-up colonoscopy, especially if you do these things at scale. What do you see as like the barriers and opportunities there if we were to do a very large-scale screening program using the fit tests as you described? How do we make sure that people get what they need if they're positive on this test?
Yeah, when we think about, broadly speaking, some of these social terms of health that have a significant but often negative impact on things around colon cancer screening, a major factor is transportation. A lot of folks, particularly depending upon the kind of work they do, can't take that time off and don't have transportation to get to a clinic or hospital-based clinic where they can get the procedure done. And so that's important information to know, but creates an important idea for us to begin to think about in terms of how do we bring colon cancer screening, including colonoscopy, to those spaces and communities in need. I think one way to think about addressing that issue would be to engage either private practice gastroenterologists to begin to provide these resources to that community, as well as health departments. And there have been conversations, and there are examples around the country where state funding mechanisms have worked with private practice, GI, as well as with the local county health departments to provide those kinds of resources in those spaces where they need it. That's sort of one issue to think about. And the other piece is just sort of paying for it, broadly speaking. Right now, we're seeing in this country, unfortunately, a lot of spaces and states where Medicaid funding is being cut back, and Medicaid as well as Medicare funding, particularly when you think about the age of people when they're getting colonoscopies, is really, really important in terms of providing the resources to ensure that these procedures are done and paid for, and that we are not leading to medical financial bankruptcy because people are trying to get appropriate colon screening done. And so as we think about health policy and economic policy related to it, it's important that we support that Medicaid and Medicare network for our patients to ensure that we have the funding necessary to get proper screening.
So, Julius, tell us, for the average listener, how should people think about concerning symptoms? So this is top of mind for all of us. And I think we tend to be hyper vigilant when we know that, I may be at risk for something that I didn't realize I was at risk for. Maybe I thought, I was young and active, don't have to worry about this. And then I read these stories of people who are apparently healthy who develop colorectal cancer. What should people be looking for? Is it change in typical bowel behaviors or other symptoms that we should pay attention to?
Yeah, it's funny. We did a TikTok study where we looked at TikToks about colon cancer to understand more about what are some of the things that people are saying out there, what are some of the true things, what are some things that are not necessarily accurate. And it was very, very interesting. And so what you're speaking to right now is a really important question, Emily. And the first thing I'll say is that, unfortunately, with colon cancer, a lot of times there are no symptoms. That's why screening is so important, because there could be no symptoms and you could have either a concerning polyp or even a cancer in the colon. And that's why we have screening guidelines to begin at a certain age, because of the data and evidence around your risk of those things happening as you get older. And so I say, first of all, that's why screening is important, because sometimes there are no symptoms. But to your point, there often are symptoms, and those symptoms can vary from person to person. It's not unusual to have significant abdominal pain. If you have significant abdominal pain and you're no longer having normal bowel movements, we worry about an obstructive process that could be related to colon cancer. Certainly, if a person were to develop blood in their stool, you should speak to a gastroenterologist or primary care physician about having a colonoscopy done. If you begin to notice a significant change in the caliber and consistency of your stool, generally speaking, we would recommend a GI evaluation. That could be colon cancer, but it could be another process in the colon that would merit you having a conversation with a specialist to work up and understand and potentially treat. And another thing that's not really a symptom, but something important for people to be aware of is that if you have a family history of colon cancer, it's not necessarily a symptom, but it's a big risk factor. And having that conversation with your family members, does anyone in my family, particularly first degree relatives, mother, father, brother, sister, or multiple second degree relatives like 2 aunts or a couple cousins, something like that, in that setting, you should have a conversation with your primary care physician about starting your colon cancer screening earlier. And not just colon cancer. If you have a family history of polyps, particularly large polyps, we would also encourage you to start your colon cancer screening earlier in that setting as well.
That's fantastic advice. I'll say the other bucket of advice that there seems to be an abundance of is around what we should all be eating and drinking. And you mentioned TikTok, and I'll say gut health is on fire on TikTok. And, right now, if that was your main source of information for gut health, you would be buying your kombucha, taking your probiotic gummies. Is any of these helpful? What do we know about whether this stuff works? And I'll just add a caveat that I have become a very unlikely kombucha fan out of nowhere. I'm not that kind of person. It's not how I identify. And I tried it and now I'm fully addicted. So this stuff is powerful in some way, but tell us what you know about some of these products in gut health.
Yeah. The data on those products is pretty skinny. I'll put it that way. And so if you like kombucha, go for it. If you enjoy engaging in that and drinking that and it's not hurting you, there's nothing wrong with doing it. I will say that generally speaking, we know that the microbiome in the gut, that normal bacterial flora that lives in your gut, is really important to your health in so many ways. Certainly in terms of inflammation and damage in the lining of your colon that can potentially lead to polyps and colon cancer, but also in terms of your immune system, in terms of your mental health. I mean, there's so many different unique mechanisms that we're beginning to connect now with the gut microbiome and your overall health. And so doing anything you can to support that the best way you can makes perfect sense. I have many patients that, when they've had changes in their stool, there's no other concerning issues, we'd recommend a probiotic to kind of help reset the gut microbiome to those sort of spaces and levels of bacteria that we know are consistent and typically are going to be good, relatively speaking, for your overall gut health. And I always encourage my patients to engage in those things as long as they're not having concerning symptoms like severe constipation, severe diarrhea, or other changes in terms of their health. I will say some of those dietary things that we do and my patients have led to diarrhea. Some of those things have led to issues with bloating. And so just be cautious and listen to your body if you do engage any of those sort of probiotic gummies or the kombucha. And I would also say that I've never been I'm a liver doctor. And so this is my bias. And I'm always against supplements because those things are not FDA regulated. They may be FDA approved, but they're not FDA regulated the way your normal prescribed medications are. And so in that setting, you never really know what you're getting sometimes. And you got to be careful because those things can sometimes hurt you, including your liver often, which is the organ I love the most. And so being careful with that's going to be important also.
That's great advice. Thank you for helping us sort of see through a very noisy and chaotic space, and good place for people to start to approach it with caution, and then also to, of course, check with their physician if they still have questions. So really appreciate you coming and talking with us today about the latest research in this space, the exciting work that's coming on the horizon, and the importance of screening, especially for people who are at higher risk. So appreciate you taking the time, Julius.
Yeah, happy to be here. I really appreciate you taking time to ask these important questions and have this important conversation.
Well, those were two very interesting conversations. We started with Dr. Ajay Kohli, who's an ER doctor at Duke, who was himself diagnosed with colon cancer when he was just 42 years old. And then we got to hear from Duke gastroenterologist Dr. Julius Wilder, who has been not only following the research and really seeing the trends in the epidemiology of colon cancer, but then also seeing how this impacts the patients who are coming into clinic every day to see him and the questions that they ask, the kind of information that they're looking for, and the kind of support that they need to make decisions about screening and about their health. I wanted to highlight a couple of key takeaways from these conversations that have really changed the way that I think about colorectal cancer as a condition and that I hope will be helpful for our listeners. The first one really is that colorectal cancer isn't just an older adult disease anymore. We've seen really big increases in people under the age of 55. And so we really should drop this concept of being too young to be at risk from our conversations and from the way that we think about this. It's important to update our knowledge as we have more data. And what the data suggests now is that we are seeing increases in risk and that there are people out there who would benefit from screening and would benefit from additional diagnostics and care from people like Julius, who are available to help us navigate this new environment. It's pretty incredible to hear Ajay's story of running a half marathon one weekend and receiving this really life-altering diagnosis of colon cancer. And what was particularly striking to me was that his labs and scans were normal for the most part. And he ended up having to have a colonoscopy to actually detect the cancer. It was interesting to see the connection to Julius's overview of the updated screening guidelines. The age of screening is now 45 for people who are average risk. And this could be even earlier if people have symptoms or a family history of colorectal cancer that puts them at higher risk. So it was great to hear from Julius about the evidence base behind those guidelines and his hopes in terms of really bending this curve and hopefully stopping these trends in rapidly rising incidence of colorectal cancer. It was also good to get a little bit of a gut check, so to speak, on the trending products in this space and really to hear Dr. Wilder talk about the basics really being the focus for what he tells patients. Things like increasing fiber intake, increasing activity, avoiding smoking, avoiding processed foods where possible. Those things are going to have a bigger impact on individual health and on population health than any supplement or trendy probiotic product that you can get your hands on. Probably my biggest takeaway is this recommendation not to delay screening. I think some people have complicated feelings about colorectal cancer screening and what it involves, the discomfort, the inconvenience, but just because you feel healthy doesn't mean that you're safe. It's a condition that can affect anybody, even the marathon runner or the ER physician. Having a colonoscopy now is way easier than treating cancer later. We have a special treat for our listeners on our next episode. We're going to be turning the spotlight on ourselves and asking some more personal questions to get to know one another better and to share with you all a little bit about ourselves, what brought us to research, what gets us excited to get out of bed every day, to come take care of patients and do clinical research. But we also want to let you know a little bit about some of our backstory and how we got to where we are. One of us may have attempted to fail out of Vanderbilt. That's just one of the little tidbits that you might expect to hear. Thanks for joining us for this episode of Beyond the Endpoint. As always, reach out to us with your thoughts or topic recommendations at beyondtheendpoint@duke.edu. We hope you will join us for the next episode of Beyond the Endpoint.
This has been Beyond the Endpoint. Resources related to this episode are available on dcri.org/BTE. If you have any burning questions about clinical research or healthcare, drop us a line at beyondtheendpoint@duke.edu. We'd love to address your questions in a future episode.